Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed to be here on the platform of MAPICON being held at Bathinda under the dynamic leadership of none other than our own Dr. Vittal Gupta. The topic given to me is NOAC navigation in CCS, a case-based presentation. The good news is NOAC has come to stay in CCS. It is safe, effective, and promising, better compliance and adherence, useful in CCS, PAF and staff, in CCS with DVT, VTE, and P and T, NVF, valvular atrial fibrillation, bioprosthetic valve, and the most important thing is no monitoring is required as compared to SNO-coumarin or warfarin. Now, if you see the NOAC in CCS, other benefits is quick onset of action and quick offset of action. First line management, low dose or low bleeding risk, low drug interaction, very cost effective. And there is enormous morbidity and mortality benefits, and antidotes are available for all the NOACs. Useful in CCS, VTE, and ATE. So what's the bad news? The bad news is NOAC in CCS, that EGFR, when less than 15, we can't use NOAC. And when it is less than 15, we use only VKA. And EGFR, when 15 to 30, we use Rivaroxaban. So Rivaroxaban is more powerful, more potent, and more promising. Hepatic insufficiency, we don't use it. And there's a black box warning, especially when metallic valve is used, NOAC cannot be used, only VKA is used. So the indications of VKA like warfarin or coumarin are very, very low acetron. Only when there is an end-stage renal failure or when a patient has got metallic valve or it's a pregnancy, lactating mother, malignancy, antiphospholipid syndrome, we use VKA. Now, who is the pioneer of principal investigator COMPASS trial, where the Rivaroxaban was used extensively in chronic coronary syndrome? Dr. J.W. Ekenboom from Canada is a key person. See the historical aspect of anticoagulants. We see here, it is almost 110 years now that we are using anticoagulants in various forms, from heparin to enoxaparin to fondaparinux to oral anticoagulants, VKA, and then NOAC 2 inhibitors, especially 10A inhibitors. Stuart Canoli was the first, is used in non-valvular atrial fibrillation. And now in 2017, in CCS, Ekenboom, again from Canada, who has done a very, very nice, very well conducted trial, COMPASS trial, shown the power and promise of Rivaroxaban with CCS. Now, ACS, management by coronary intervention, by effective pharmacological intervention has been the rule up till now. Instead of DPIT, these days we use P2Y12 monotherapy, which is safe and effective. And after 3 months of PCI, we use only one monotherapy. It's quite common after 1 year. CCS, very, very common. It is misunderstood or misunderstood or not understood. If you see Rivaroxaban 2.5 milligram BD plus ASA, promising and effective, and there is enormous morbidity and mortality benefit. What is the agenda today? The agenda is CCS burden in India and Southeast Asia is rising. NOAC navigation in CCS is the need of the hour. To evaluate NOAC safety, efficacy, outcome, and evaluation, and choices in CCS and other comorbidities is the main agenda today. And to discuss the morbidity and mortality benefits of NOAC in CCS and to compare the benefits and hazards. Now, if you see from European Heart Journal, the classification of ACS and CCS is very well known to you. ACS is like STEMI, non-STEMI, and unstable angina, while the CCS is like stable angina, new heart failure with suspected CAD, stabilized symptoms less than 1 year, or stabilized symptoms more than 1 year, or patients with microvascular disease or asymptomatic CAD detected on screening. CCS is a dynamic process because there is a platelet activation and there is a thrombin regeneration. So it's a dynamic process which is happening all the time in us. Now, to start the case presentation, a 56-year-old male arrived in emergency with a history of severe chest pain and sweating of 1 hour duration. He was diabetic, hypertensive, and the blood pressure at the time of admission was 110/70, heart rate was 52. Within 10 minutes of immediate initial assessment, management was executed and the ECG was done, tropi and echo was done, and initial measurement steps were patient was given IV fluids, IV opiates, and the ECG revealed acute inferior wall MI. His tropi was high, creatine kinase were also high, ejection fraction by echo revealed 55% with a severely hypokinetic inferior wall. So the diagnosis is very clear. Inferior ST elevation MI. Patient was immediately shifted to the cath lab for angiography. And pre-PCI cath lab, patient was given the dose of P2Y12 inhibitor along with the aspirin. Now see the power of ticagrelor. Ticagrelor inhibits the platelet aggregation by almost 89% as compared to clopidogrel or prasugrel. So ticagrelor has a real power to inhibit the platelet aggregation. So that's how we use ticagrelor plus aspirin plus high dose of statin pre-cath in every patient these days. We don't use clopidogrel, but we use ticagrelor 90 mg BD. Patient underwent PTCA with coronary stenting in the infarct-related artery. Echocardiography was performed. It demonstrated very mild hypokinesis of the inferior wall with a preserved LV and RV function. We can see here clear-cut 100% cutoff of the RCA, and after the angioplasty, we can see in this frame that there was a total recanalization. Post-PCI at discharge, patient was on oral antiplatelet drugs, which continued as ASA on the maintenance therapy. The Plato study has shown very clearly that ticagrelor decreased the CV events from 30 days to 12 months. There is no doubt about it. There is a huge data to support, indicating that ticagrelor is superior to clopidogrel as expressed in this slide. And we see here the primary outcome, MACE plus revascularization, is shown very clearly that it was reduced by almost 53% as compared to clopidogrel. So ticagrelor is definitely superior as compared to clopidogrel in view of MACE reduction and revascularization reduction by 53%. The prasugrel we don't use anymore because there's a major bleeds, and of course there was a limitation as a black box warning of increased risk of severe bleed, and dose adjustments is required if the weight is less than 60 kg. And of course, there is a history of stroke or TIA. Ticagrelor promise is a one-stop solution, regardless of diagnosis, whether a patient has got unstable angina, on a non-ST elevation MI or ST elevation MI or chronic CCS, on medical treatment or PCI or post-CABG or fibrinolysis, and can be used in any patient with ischemic stroke, age less than 18 or more than 18, irrespective of weight or sex or diabetes or genotypes. So the prescription changes to aspirin 75 OD, ticagrelor 90 mg BD, atorvastatin 80 mg OD, metoprolol 50 mg OD, telmisartan 40 OD, and vildagliptin plus metformin and metformin at night, and of course lifestyle motivation and adherence to all the medication. And this patient was requested to come for a follow-up after 1 month or next 3 months. Now how can we shift a patient of DPIT to ticagrelor alone as a monotherapy after 3 months? That's a point which we like to discuss here. And here is the data. PILAT study has shown very clearly a total number of patients of 7,119. It is shown that the bleeding risk is reduced by monotherapy by more than 44%, which is a very, very significant benefit of ticagrelor alone as compared to Ticagrelor with aspirin. And this is a guideline which is known to all of us, ACC and AHA, published in 2016, shown as the power of DPIT, which we had been using for 1 year in the past. And the medication continued for 12 months. Aspirin 75 milligram OD, Ticagrelor BD, Atorva, Metoprolol, Vildagliptin, Telmisartan, and Metformin. Now the question is, NOAC and CCS after 12 months, how do we use? What is the protocol? This is to show by the REACH registry. The REACH registry has shown a very clear-cut data that the total number of patients were 64,977, more than 45 years of age, and they've shown that the ischemic episodes less than 1 year are 21% and more than 1 year 17%. So almost 20% of the population after MI is prone to have chronic coronary artery syndrome. So 1 in 5 patients are event-free 1 year post-MI had MI, stroke, or severe death within 3 years. This is a very, very important information. Now, out of these 20%, 40% had MI, 18% had stroke, and 40% had severe death. So we should take it very seriously, the role or application of Rivaroxaban to reduce this event rate and mortality of CVD by 20%. So does it mean stable CAD or it's a myth? The answer is it's a myth. The exact label should be CCS, that is chronic coronary syndrome. What should we use? SAPT or DPIT or DPIT? DPIT is a dual pathway inhibition. DPIT we have been using as a dual antiplatelet therapy and single antiplatelet therapy. Now see the data. The data is very clear with SAPT. If you follow up for 1 to 2 years, the MACE rate is 19%, mortality is 9%, and the stroke rate is 19%, MI is 20%. Same thing is shown here, and the mortality rate is quite high if you use SAPT, and the hemorrhaging rate is quite high. So current unmet needs from SAPT and DPIT are no mortality reduction. That's a very important point. Only MACE reduction, but not mortality. So no significant benefits of CV death reduction, no significant benefits in all-cause mortality reduction, and no significant benefits in major adverse limb events. So we need something to cause optimization of vascular protection. And the answer is DPIT, that is platelet activation to be reduced and thrombin generation to be reduced. Rivaroxaban is the best drug which is used in COMPASS trial as a dual pathway inhibition therapy which optimizes the vascular protection in CCS. Why a vascular dose of Rivaroxaban is 2.5 milligram BD with ASA and could be is most preferred option for CCS. And the data here is shown in 27,000 patients where CAD was 91%, PAD was 27%, and of course the patient divided into 3 categories: Rivaroxaban with aspirin, Rivaroxaban alone, and aspirin alone, and they were followed up. Antithrombotic investigations were stopped within 1 year ahead of expectation in February 2017 due to overwhelming efficacy of Rivaroxaban 2.5 milligram BD with aspirin. So what is the criteria of inclusion in CAD and PAD? Previous MI, last 20 years, multivessel disease, unstable angina, or a multivessel CABG, or any individual more than 65 or less than 65 plus atherosclerosis, more than 2 vessel disease, or 2 additional risk factors like smoking, diabetes mellitus, or EGFR less than 60, heart failure, or non-recurrent infarct. While in PAD, they used ankle brachial index less than 0.9 or significant peripheral artery disease. They were all the criteria of inclusion. Now see the vascular dose of Rivaroxaban and aspirin decrease the MACE rate by 24%, and the CVD mortality is reduced by 22%, while the overall mortality is reduced by 18%. COMPASS trial has shown very clearly that the MACE rate reduction by 24%, net benefit of 20%, and mortality reduction of 18%, while no benefits are seen with the Rivaroxaban alone. So the combination really worked, Rivaroxaban with aspirin. And we can see here the data. The stroke rate is reduced by 44%, CV death by 25%, and all-cause mortality reduced by 23%. The clear net clinical benefit of 20% is seen. The COMPASS trial bleeding rate is also quite low, 2.3%. And we see here that the reduction in the amputation was almost to a tune of more than 70% when they use a combination of Rivaroxaban and aspirin. So this is very, very important information we had in the subgroup analysis. So the NICE trial, NICE guidelines have also shown very clearly Rivaroxaban plus aspirin is recommended as an option for preventing antithrombotic events in adults with CAD or asymptomatic PAD who are at the high risk of ischemic events. Viagra data has shown the same thing here, that the primary endpoints in the form of acute limb ischemia, major amputation, myocardial infarction, ischemic deaths are significantly reduced in a Rivaroxaban group. This is just to compare Charisma trial with Pegasus TIMI 54 and COMPASS trial. It is shown the risk reduction of MACE by 24%, CV death by 22%, and 18% is mortality reduction. Now, evidence supports the use of Rivaroxaban 2.5 milligram BD because the dose escalation study leading to selection of 2.5 or 5 milligram, it was used in ATLAS trial, where the number of patients was 3,491 in ACS in 2009. While in 2012, again, ATLAS trial, in 15,000 patients, they used Rivaroxaban 2.5 BD to DPIT and reduce the severe risk and all-cause mortality. And we see here in the COMPASS trial, number of patients were 27,000 in 2017, and there is a very, very significant reduction of mortality as well as morbidity. Now, if you see the guidelines, like European Society of Guidelines, they have shown the usefulness of NOAC as compared to VKA in every patient of atrial fibrillation, with the class of level of evidence is A and class of recommendation is 1. And the same thing is seen here. We see down below that in 2019, in the Global Vascular Guidelines also favors the usefulness of Rivaroxaban and aspirin in patients of CCS and PAD, and the same thing has been used to reduce the ischemic events in the patients with the CCS. To conclude, ladies and gentlemen, after 1 year of ACS, CCS ischemic burden is quite high. I mentioned to you up to the tune of 20%. Vascular dose of Rivaroxaban with a low dose of aspirin prevent clot formation through DPIT strategy. So we should individualize our patients on ischemia and the bleeding risk ratio. DPIT is definitely superior to DPIT and SAPT in mortality and morbidity reduction. Rivaroxaban 2.5 milligram is the only NOAC which has been approved both for ACS and CCS. Please remember, it is Rivaroxaban and not other NOAC like Apixaban or Rivaroxaban or Dabigatran. COMPASS trial has also shown that it was terminated 12 months in advance because the results were so good, and the Viagra data has also shown a significant reduction of the MACE events and the amputation. What's the take-home message? The take-home message is health of millions is at stake with CCS and comorbidities in India. Timely NOAC intervention is the need of the hour, especially with the Rivaroxaban. DPIT is superior to DAPT and SAPT, and DPIT mortality and morbidity reductions are enormous. We must act locally and impact globally. Ladies and gentlemen, the revised prescription after 12 months post-PCI, aspirin 75 milligram, and instead of Ticagrelor Rivaroxaban 2.5 milligram BD, atorvastatin to continue, metoprolol, telmisartan, vildagliptin, and metformin to continue. This is what I wanted to show. On one side is a lion with a DPIT, and on the other side is a tiger with DAPT and SAPT. Choice is purely yours. The mortality benefit and the morbidity benefit are enormous with DPIT in CCS. Thank you very much for your kind attention. Thank you.